Recording in progress.
Hi, everyone.
Hi, President Denise. I missed the meeting when you did the technical testing. So is it Han-Min who will start the program, and then we will have to just call me, and then I'll introduce and call all the presidents, right?
Yeah.
Okay,
Then
perfect.
after that, you can either pass to Denise, or I can just introduce Denise, either way.
I think I'll just let you introduce my mom, Denise, too.
Okay.
一大黃少。哦，喂。咩閂門嘅？
啱你入去啊！
入知啦，走啦，我開緊住。
Okay, later maybe we can start at around 2 o'clock. Yeah. Okay, so maybe we can start promptly at 2 o'clock. So perhaps we can start admitting the participants now.
Okay.
Thank you.
Oh, Mr. Cornelio, you wanna test your mic?
Hello, mic test. Can you talk whether I can hear you?
Yeah, we can hear you.
Oh, perfect.
Thank you.
Hi, good afternoon, everyone. Wow. The millennials and the promising professors of SSR. You can see from my hair, you're all still hairy. Only my
Good
eyebrow.
afternoon, Cornelio.
Good to
Thanks
see
for
you.
joining us today.
Yeah, of course, my pleasure, and I'm so happy that we are given the chance to share our little experience in. I hope we have a very fruitful and learning and sharing session today. Because I feel like I feel so sleepy. It's siesta time. I know your faces. Yeah, President Dennis. Thanks for organizing this. I'm a little bit pressured because I don't know what questions are coming up soon. And have you reviewed my recorded video?
Yes, I think Hanin was able to try it a little earlier.
Oh,
I saw some of it playing,
yeah.
so it should be good to go.
Oh, okay. So what time are we going to start? I think. All right. Thank you, Sukai, for entertaining my messages. All the inquiries of this CPD Asia.
It's great to have you on board here today to share with us. Thanks for coming in.
I think I need to help me to post my email if in case I'm not able to answer all those inquiries and questions. So
Sure, I think we can post in the chat later so that if there's any leftover questions that have yet to be answered, I guess we can take this offline.
correct. Yeah, because it's going to be a very short Q&A. And what I realize sometimes it is a post session that comes to questionnaires. And that's the only time you can answer more in detail,
Yeah.
The good thing now in Singapore, we have 500 CT, I think 5 or 6. Yeah, if I'm not mistaken, and it's continuously growing up. That challenges our IR radiographers now.
Yes.
Yeah. And it's not just operating the system, but radiologist is sometimes relying on your decision as well. You'll be part of the decision making during intervention. That makes a little bit difference. So it's very tough. That's why I'm running on the city for. Yeah, I don't know whether it's discouragement or encouraged. But anyway.
I think
Alright.
if we're ready, we'll just start the session. Maybe Hamin
Okay.
over. Yeah.
All right. So, welcome everyone to the 30th Asia CPD. And my name is Han Min, a council member from the Singapore Society of Radiographers. And today I'll be hosting the session. All right. So, first up, I would like to invite Ms. Peachy Luna, Secretary from the Philippines Association of Radiologic Technologists, for the opening address. Ms. Peachy, please.
Yes, thank you, Hanmin. Hi, everyone attending this 30th CPD Asia, and most especially to everyone from Singapore. This CPD Asia is highly supported and embraced by many member societies, presidents, all the officers, and their representatives. Let us greet and welcome President of Macau Radiological Technologist Association, MRTA, President Fernando Koch. President Fernando Koch, are you there? We've seen you. While waiting, we would like to greet you a happy birthday today. All right, we'll get back to President Fernando Koch. For now, we also would like to greet the President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, or PARI, Dr. Giek Sugianto. President of Vietnam Association of Radiological Technologists, VART, President Thai Van Loc.
Hello, everybody. Hello, everybody. Good afternoon. Thank you, Singapore Society, organized today, Asia CPD today. Thank you.
We also have the President of Hong Kong Radiographers Association, HKRA, President Wan Shin Boon Nelson.
But today I'm attend the CPD Asia. Yeah, hello.
Yes, yes. Good afternoon, President. Mr. Tan Tat Ming. The VP now is President is VP Wan Shin Boon Nelson, right? All right. Attending also is for President Chun Yuan Tu of the Taiwan Association of Medical Radiation Technologists is Miss Alice Chang, who is the Vice Chairman of the International Affairs Committee from Taiwan Association of Medical Radiation Technologists.
Hello, everyone. Good afternoon. It's happy to see you all, and thank you.
Good afternoon. We also have the President of Malaysian Society of Radiographers, President of MSR, Sir Sawal Marsait.
Hello, hi, everyone. Good afternoon and happy Saturday. Thank you.
We also have President of Indian Society of Radiographers and Technologists, President Salva Kumar. Attending for President Sir Katsuhiko Ueda, the President of Japan Association of Radiologic Technologists, is Akita. Sir Akita.
Hello, all my friends. So today I am representing the Chairman Ueda. So thank you.
And we have greetings from the Philippine Association of Radiologic Technologists, President Rolando Banares, to President Sophie Lee of the Association of Cambodian Radiological Technologists, from President Mohammad Abdul Ghani of the Palestinian Association of Medical Radiation Technologists, PAMRT, and to all our friends, officers of Myanmar Society of Medical Radiation Technologists. And also, Hanmin, we have invited panelists who will be joining us later. We have President Vincent Kuo Wei Wang of Taiwan Society of Radiological Technologists. And also—
Hello. Okay, hi everyone. I see a lot of old friends here, and thank you everyone to join. I'm thrilled to have been invited to participate in the CPD platform, and I would like to express my sincerest gratitude. And this platform provides invaluable opportunity for the professional growth and the contribution of radiological technology, and I'm honored to be a part of it. And as a president of TWSRT, I think that the CPD platform provides a leadership skill and talent have inspired many, including myself, to continuously strive for excellence and expand our knowledge. And I think that your commitment to evaluating the professional standard of radiological technology has not only brought glory to our field, but has also provided higher level of medical service to our patients. And once again, thank you for the invitation. I look forward to learning and grow within the CPD platform and continue to contribute to our professional community. Okay, thank you.
Thank you, President Vincent Kuo Wei Wang of Taiwan Society of Radiological Technologists. Also, we have President Vitrana Garnage Vimalasena of the Society of Radiological Technologists, Sri Lanka.
Hello. Hi, everyone. Good afternoon, everybody. So it's my pleasure to be here in this panel today as a part of the CPD Asia program organized by the Singapore Radiographers. In fact, I must thank all the organizers and all the pioneers of the CPD Asia program, especially Mr. Fernando Koch, Dr. P.C. Luna, Mr. Taiwan Lo, and all the leaders of the societies involved in this program. We are glad to be the part of the Asia, CPD Asia family, and we are the new members. And we are looking forward to organize this type of webinar to upgrade the professional standards of the radiographers by sharing the knowledge and experience to upgrade the membership. So it is great pleasure, and I wish all the best and congratulations for the people webinar today, and have a good day. Thank you very much.
Thank you, President Vitrana Wimalasena. We also have Nom Koranang, the chairman of MRTA.
Hello, nice to meet you all on the 13th of CPD Asia. Hello.
We have Ma'am Joyce Tan, ISRT Regional Director for Region Asia Australasia PRO. Hello, Ma'am Joyce.
Hi, good afternoon.
And again, we'd like to say hi again to President Salva Kumar of the Indian Society of Radiological Technologists.
Hi, very good morning. Happy to see you all after a gap of few months. Thanks for this. We are reached the 30th CPD Asia. Congratulate all the entire team for making it a grand success of the programs. Really a wonderful occasion. And we took this opportunity to wish our Fernando Cox sir a happy birthday too on this special occasion. And all the best for the 30th CPD program. Thank you.
Thank you, President Salva Kumar. And last but definitely, we should never miss President of MRTA Macau Radiological Technologists Association, President Fernando Cox. Are you now here with us?
I think he's busy in celebrating birthday.
All right. So then I'll be handing it over to Han Min again to continue with the program.
Thank you, Ms. Pichi. Next up, I would like to invite Ms. Denise Chung, President of the Singapore Society of Radiographers, to say a few words. Ms. Denise, please.
Thank you very much, Han Min, and a very good afternoon to everyone on this sunny Saturday afternoon. Thank you for taking the time to join us at the 30th CPD Asia session. It's really impressive that we've reached the 30th session together. And this time it will be hosted by the Singapore Society of Radiographers. And I'm so glad that we've managed to stick through this. And it's been almost 3 years actually since we started the CPD Asia program. And I'm really proud that we have grown this community together. So I want to also take this opportunity to welcome our new friends who have joined us most recently, our friends from Japan and Brunei, the Japan Association of Radiological Technologists. Mr. Akita is here representing JART today, and also our friends from the Brunei Ministry of Health. So welcome, and I'm so glad that you've come on board to join us on our team that's dedicated to making continued professional development accessible to radiographers and radiological technologists in Asia. So I would like to extend my gratitude also to the SSR academic team and the IT team that has always been helping to make CPD Asia a successful session. And of course, I would also like to thank our two speakers for coming on board today and sharing their knowledge and experience with us. So without further ado, let's get the session underway. And I would hand the time back over to Han Min to introduce the first of our two esteemed speakers for today's session. Over to you, Han Min.
All right. Thank you, Denise, for the kind words. Without further ado, we will commence the 30th Asia CPD session with a presentation from Mr. Cornelio Gutierrez Padre. So Mr. Padre is an accomplished principal radiographer specializing in interventional imaging at Singapore General Hospital. His qualifications include a diploma in radiologic technology from St. Louis University, a Bachelor of Science in Radiologic Studies from London South Bank University, and with 35 years of experience, he worked at Makati Medical Center before joining SGH in 2000. Since 2008, he has excelled in operating the hybrid angio-CT system and improving intra-atrial CT angiography protocols. He's a founding member of Canon NGO-CT and an exclusive member of Canon AFINC's 4D CT. Currently, Mr. Padre is a clinical modality leader in interventional imaging at SGH and serves as the president of the Association of Filipinos Radiographers in Singapore. Today, he'll be sharing with us about operating a hybrid angio-CT system, which requires radiographers to master both angiography and CT imaging techniques, including skills in patient positioning, protocol selection, and adjusting imaging parameters for optimal results in both modalities. Moreover, the integration between these two distinct imaging methods requires expertise in the hardware and software components of the system. In essence, managing a hybrid angio-CT system mandates radiographers to possess a multifaceted skill set encompassing angiography, CT imaging techniques, along with a deep understanding of the system technical aspects. So without further ado, let's begin the session.
Good afternoon, everyone. This afternoon, I'll be talking about the challenges in operating hybrid angio-CT system during interventional procedures. The learning objectives for these presentations are the following. The participants will be able to understand the role and challenges of radiographers in operating hybrid angio-CT systems, the benefits and clinical applications for vascular and non-vascular interventional procedures, and to discuss the technical considerations involved in any successful intra-arterial CT angiography. Just a little background of the hybrid angio-CT. It was developed by Professor Yasuaki Arai from NCC Japan in 1992. SGH acquired the very first angio-CT in 2008, and the second angio-CT was acquired in July 2016. In 2021, we replaced our very first angio-CT system installed in 2008. Okay, here, if you see the left picture, this is where the table position during angio procedures, and on the right side, here is where the table and the gantry positioning. So if you notice, it is the gantry that moves during scanning, unlike the diagnostic CT. So as I mentioned earlier, we have our very first angio-CT, second, and the latest one, which has replaced the old one. The difference between these two is the number of slices. The gantry aperture are exactly the same, but the one volume coverage, the 160 slice only 4 cm, but the 640 slice cover 16 cm. Equipments to be operated are the following. You have the angio CT injector advanced workstation, the ultrasound machine, and additional standalone workstation. This is just to show you the fluoroscopy imaging involved, from the simple to CT guided, the combination of ultrasound and CT, and the more complex procedures combining the ultrasound, CT, and angio system. For fluoroscopy imaging, you have the DSA, and the digital fluoroscopy, cone beam CT, and rotational. For CT, you have your intravenous, intra-arterial, and CT fluoroscopy. For ultrasound, just routine ultrasound imaging, saving, some fusions, and contrast enhanced. So for the role of radiographer, it is divided into three: the pre and intra and the post procedures. I think the most challenging part here is the during procedures, where the radiologist might be asking you to set up some injection parameters. So either the radiologist or you decide, you must have an idea in what is the ideal flow rate of PSI in a certain catheter or vessel injection area. And of course, controlling the CR on the table. I understand in some places it is not the radiographers controlling the CR on the table.
But for post procedures, the charging of consumable items, it is our responsibility. Post processing, archiving of images, and completing the study, and of course, analyzing the image and techniques being applied for the entire procedures. So for the challenges, there's a lot of angiography is very complex, and these are the challenges that the radiographer will be encountering. For the CT scan, it is expected to perform CT fluoroscopy, IVCT, CT angiogram, ICT, advanced workstation, understanding the automatic contrast software and limitations, evaluate and analyze images, and continuously reviewing the image workflow. Of course, collaboration and adapt the never-ending technological advancement. These are the terminologies I'll be mentioning for the rest of my presentation. So in intervention, you have two major categories. You have the vascular and non-vascular procedures. For non-vascular procedures, we are performing RFA liver, lung or kidney, cryoablation for kidneys, vertebroplasties, biopsies, complex drainages, and some ultrasound guided biopsies. So this is a good example of the system setup during non-vascular. This is a RFA liver. You can see the GA machine on the right side. You have the gantry, you have the ultrasound, and from the behind the gantry, here is where the GA tubing goes through, and the side view, so you can see the GA tubing was supported by this special board. For RFA liver, these are the things that radiographer need to prepare: ultrasound machine, prepare for fusion imaging, and automatic contrast injector unless it is contraindicated. And make sure the 18 gauge or 20 gauge cannula was inserted for intravenous contrast injection, and identify the cannula and check ECG and BP cable's position. So this is how we usually position during RFA. So if you notice, because of the possible brachial plexus injury, we stop raising the right arm of the patient above the head. So this expected imaging during RFA liver. It can be ultrasound, and CT alternately. So there's no straightforward imaging during RFA, but the most important thing is the post-ablation. The RFA four-phase CT liver is routine to check the ablated area and to identify whether there is a bleeding complications. This is just the straightforward ultrasound guided RFA liver. You see the lesions on the left side, and the middle is where the probe, and the right side is the post IBCT liver. But during the insertion of the needle, the ultrasound fusion was used, even the contrast enhanced ultrasound. What about renal cryoablations? So in this particular case, the patient is in a lateral decubitus position. CPD needle inserted for pneumo and hydrodissection to move the kidney away from the colon, and 2 ice-force cryoablation probe, and 2 times 10 minutes freezing and 5 minutes thawing. So again, under ultrasound and CT scan has been used. For this particular case, the preliminary scan was done using the fine needle for hydrosection, and probe positioning was decided during the preliminary CT scan. So as I mentioned earlier, the preliminary scan was done. You get the markers, and you have the cryoprobe, needle planning, the needle planning, and here is where the hydrodissection. You can see the hyperdensity there. So displacing this column from the kidney, and this is the first cycle, 10 minutes freezing, and this is the second cycle, 10 minutes freezing. So in NPR, you can see the hyperdense shadow of the ice ball. You can see the needle, and this is the second cycle. See the relationship between the needle and the ice ball. But prior to freezing, the ice ball testing has to be performed before the needle was inserted. So to complete the study, for post-cryoablation, you can see the arterial phase, you have the nephrogram phase, you have the delayed phase. So there's a sort of something like small enhancing here, but the question is this a remnant tumor or is a bleed? So in comparison from diagnostic to CT, post-cryoablation, this is the tumor and this is your immediate post-cryoablation. Now you don't see the heterogeneous appearance of the lesion. After 6 months, there's a follow-up for contrast-enhanced ultrasound. As I mentioned earlier, there was a suspected either it is a remnant tumor, but based on the ultrasound and Doppler study, the CES shows no remnant tumor enhancement or recurrent post-cryoablation. So tips for non-vascular cases, sometimes diagnostic scan protocol is not applicable. The advanced software like CMR, volume CT is also an advantage. And of course, the high-end ultrasound machine is, as much as possible, has been utilized for fusion and CUS or navigation purposes. Challenges for post-RFA and cryoablation, modifications of CT imaging protocol, and image quality documentations. So this is the one I'm referring to for diagnostic CT. This is a useful monitoring scan or shoe-start ROI positioning. But for post-cryoablation, sometimes it is not ideal because of some hydrodissections. So it was decided to position the monitoring scan beyond the hydrodissection. For vascular procedure, the mastering anatomy and of course the physiology and hemodynamics, understanding the flow of procedures from ultrasound and fluoroscopy and CT. Of course, it is expected to perform DSA and intraarterial CT alternately, and the imaging workflow plus the automatic contrast injector. This is a room setup. In this particular case, this is is in the middle of procedures where the ultrasound is here, gantry is there, and you have the C-arm behind here. You have the radiographer here standing, the injector, and from the control room. So before showing the workflow for IECT, allow me to, for those who have not seen the IECT pictures before, this is the intravenous arterial, and you can see the large tumor there. But when you do an IECT HA, this is the DSA pictures. This is how it looks like when performing IECT HA. So on the other side, you can see the other supplies of the tumor. This is to show you what to be expected when you perform IECT HA. So we have 6 steps for in performing RACTSA, where in the reference DSA, table scan positioning, and moving gantry into scan position. But the reference DSA from step 1 has to be reviewed before you start the scanning. So using the angio injector for both reference DSA and RACTSA. So keeping the same injector also maintain the catheter filled with contrast. And of course the angio injector allow us to a higher flow rate and PSI for microcatheter. So talking about the step number 4 is a review of the reference DSA. Here is where you can identify your arterial to tumor enhancement or arterial to Venusians. And at the same time, you can identify how your catheter moves during injection of contrast. So look for the last image of the DSA run, and that will be your final catheter position. Identify the vessel enhancement during the DSA. So still in the same step number 4, you are able to identify the actual flow rate, actual PSA, and actual volume or dilution. So from this picture, based on the step 4, you can identify whether you need to adjust your contrast flow rate based on the reference DSA. This is very critical, especially when you're using your CT injector during RACT. So if you notice, when for the CT injector, you are only allowed up to maximum 350 psi. So if you injected the higher flow rate that would require a very high psi, it might just abort the injection. So this is how you determine your flow rate, the actual flow rate, what you set, and the actual injection flow rate. And this is how you decide whether you maintain the same flow rate in spite of having the reflux of contrast. So this is just to show you that the right lesion enhancement is just based on from the reference DSA. It is considered as second enhancement. For volume of contrast, this is very simple. As long as you identify your scan delay from the reference DSA, your scan time and flow rate, then you get a volume. For step number 5 and 6, this is the very first thing you need to do. After the RACT, you have to check your catheter position. You have to compare from the reference DSA and in the coronal view, so that you can see whether the contrast of the catheter is still in the same position. So what are the important factors for RACTA? We have the contrast injector, the catheter, the anatomy, and of course the value of reference DSA prior to RACTA. For contrast injector, you should know the type, whether it's angio or CT injector, contrast flow rate, dilution, and for catheter, you have the front size, whether it is side hole, end hole, anatomy, vascularity, and type and characteristics, the hemodynamics, and for the reference DSA, must use automatic contrast injector prior to RACT. So these are the variety of injectors that we are using. For angio injectors, we use the Medrad Mach 5, this is the old one, and we have the Medrad Stellan, and also we have the Medrad Mach 7, and still a Medrad CT injector. And this time we have the Metron Acutron with a dual mode angio and CT injector. So for the injection history, as I mentioned earlier, before RACTA, the reference DSA has to be performed. This is to give you whether the parameters being used from the reference DSA is applicable when you perform the RACT. So this is a very good example. This is your actual injection, and this is what you set injection, but the actual volume and being achieved is only less than 22 because of the PSI was very low. So because of that experience, we come up with some data wherein when you're using a microcatheter, these are the PSI that required in a certain flow rate. So based on these parameters, you can see a 1 meter per second. It requires a very high pressure from 400 to 500. So because of this, you can only inject less than 1 mil for if you're using a CT injector during IACT. And that's why we come up with these particular guidelines. So for volume, we have the simple calculation, scan delay, scan time times flow rate, and that will be able to give you more accurate volume calculation. So let me talk about the reference DSA. As I mentioned earlier, these are the information that you will get from the reference DSA. Catheter position, contrast parameters, and for scan technique, scan delay, scan coverage, and scan direction sometimes. So for catheter position, always check the last image from the reference DSA. So you can see the initial and the final position of the catheter. So either you have to adjust the catheter or maintain it. So the most important thing is you can identify what is the final position for your catheter. So from the reference DSA, this is a very good example. You can see the segment 2 and segment 3 enhancement during the DSA, and the later part is only the segment 2 which is enhancing, so it means the catheter has to be adjusted before the bifurcation. For tumors, you have to look for the tiny lesions. When you want to determine the scan delay for able to pacify the large and small tumor. This time, let me share with you my first vascular case. This is mesenteric embolization with a patient history of post-cholecystogastric fistula repair. The DSA SMA was performed, followed by RACTA. And at the bottom pictures, you can see the diagnostic IVCT, where is the bleeding point, and in the arterial RACTA is still bleeding continuously. So as you can see, the catheter was in the SMA, the origin of the SMA, and comparing the diagnostic CT, it seems like the bleeding is still active at the time, and the injection parameters was 4 mils per second with a scan delay of 8 seconds. Contrast dilution is 60 to 40. So advancing the catheter more selectively, but due to some gas shadows and some respiration during the DSA, it was not very clear whether the feeding artery was demonstrated. So it was decided to perform another RACT selectively, and you can see the MIP pictures and the 3D showing a very nice enhancement of the feeding artery. So this RACT, we give it 2 mils per second and 6 seconds of scan delay time. Now you can see the DSA pre-embolization, and on the left side you can see the post-embolization picture. What about endoleak embolization? So this is a type 2 endoleak. The type 2 endoleak is a persistent perfusion of an aneurysm to endovascular abdominal aortic aneurysm repair. It is caused by retrograde flow via collateral arteries. So for this particular case, it is a translumbar puncture because of a failed transfemoral approach for this case. The translumbal sac puncture, it is using a needle direct puncture to the aneurysm sac under fluoroscopy, and it is a direct embolization to the sac using coils or liquid embolic particles. It is a safe, effective, and high success rate technique for treating type 2 endoleak. So if you look at the left side, you can see the patients in prone position, and intravenous CT was performed. In this particular case, you don't need a proper arterial phase for as long as it demonstrates that there is still endoleak present, so we can proceed with the embolization. So since the patient is still in the same position, the fine needle was inserted percutaneously. This is a 1-volume CT fluoroscopy. You can see the axial and coronal and sagittal and oblique needle representation. Once the needle tip is in the right area, the conventional fluoroscopy was used, and saccogram was done, demonstrating the collateral vessels. So if you look at the right bottom one, you can see the post-embolization wherein you don't see the vessel enhancement anymore. So this patient came back for the third time, and based on the right side IVCTA, you can see the recurrence of endoleak, showing the yellow vessels as the feeding artery. And if you look at the left side, the DSA pictures, this is the pre-embolization, and the right side is the post-embolization. So if you're looking at the red arrow, this will represent that the endoleak is still active. And on the right side, and after the embolization, you can no longer see the endoleak. What about prostate embolization? Prostate artery embolization, it is a minimally invasive treatment for lower urinary tract symptoms caused by benign prostatic hyperplasia. And PAE can be useful as a pre-surgical embolization prior to TURP. Embolization of from prostate artery can prevent or reduce bleeding complications during prostate resection. Okay, prior to prostate artery embolization, IVCT angiogram was performed to identify the prostate artery supplies projection for both arteries. And in this case, the embolization was done in a transradial approach. So from the diagnostic IVCT, you have to identify the right and left prostate artery. And you have to advise the radiologist in what trajectory do you think you can demonstrate the left and right prostate artery. This is how we position. In a fit first position, this is your injector, and here is your Z-arm. So the most important thing in transradial approach is for you to identify the gantry position. So in other words, before cleaning the arm of the patient, the topogram AP and lateral has to be done so you can establish your approximate position of the gantry. Why transradial approach? It is less radiation and easy to access both right and left iliac arteries, and patient can embolate immediately even after the embolization. So this is the imaging involved. We have the DSA, ICT on the selective right prostate artery. So this is the right non-selective DSA. You can identify the prostate artery based on the 3D of the IVCT, and it was able to cannulate the right prostate artery, and this is the DSA. Once you catheterize in the right prostate artery, ICT was done, and you can see the demarcation enhancement here, In this particular ICT, it has a 22 seconds delay with a flow rate of 0.2 mils per second. So this is a pre-embolization DSA, and this is your post-embolization. So the moment you see the reflex of contrast, this is a sign that you are successfully embolized the prostate artery. What about on the left side? Still the same. Once the left prostate artery was cannulated, IECT has to be done again. And this is your left IECT-HA. You can see the reference DSA. On the right side, you can see the prostate artery and the prostate enhancement. This is your pre-embolization reference DSA, and this is your post-embolization at the bottom. So again, you can see the a lot of reflex of contrast because the prostate artery is already embolized. To summarize the imaging, this is your right and left pre-embolization, and the rightmost and the leftmost is your post-embolization. You got to sit in the middle, the right and left IECT. Imaging tips for IECT prostate artery embolization. Reference DSA must use automatic injector, and injection must be very slow and avoid contrast reflex. So if there's a reflex of contrast, either you have to repeat the reference DSA until such time you find the correct flow rate that there's no reflex of contrast. Why do we need IECTA? So this is to show you this particular case. This vessel, we thought this is the prostate artery, but when the IECT was done, and it was the rectum that enhanced during the IECT. And this is the particular vessel that supplies the prostate artery. Okay, for angiosity setup for search, it's almost the same as other vascular cases. You have the technetium 99M or MA and the Y90. In short, this is the imaging has to be done. You have the DSA, you have the IECT. But allow me to share with you what is the CT arterial portography. This is a intraarterial injection of contrast into the SMA or the splenic artery. This is to evaluate the liver and the presence of hepatic neoplasm, focal hepatic lesion. This is for accurate segmentation and detection of the liver in attenuation between normal liver and parenchymal and the lesion itself. So allow me to share with you some articles how this arterial portography has been performed. This article shows the volume of contrast they have injected, and they're using some sort of like monitoring for them to achieve the ideal portal and liver enhancement. So the liver parenchyma method makes it possible to conduct CTAP scanning with an appropriate timing relative to fixed and IVC-ROI methods. However, in our practice, we don't use the monitoring scan or show start, but rather we just use the scan delay of 35 seconds from the start of injection. So for workflow, once the catheter is in the SMA, this is to demonstrate the position of the catheter. Although the DSA is not optional, once you are confident that the catheter is very stable in the SMA, you can move your table into CT position and the gantry into scanning position. So these are the injection parameters given. You have the 3 minutes of contrast for 75, which is equivalent to 25 seconds. And with the saline chase of 30 minutes of contrast for 10 seconds. It can be done either in splenic and SMA, as I mentioned earlier. This is how it looks like for the SMA. And on the right side, you can see the splenic CTAP. For the left side, you can see the left hepatic and right hepatic huge tumor and tiny lesion on the left side. A heterogeneous liver enhancement may be due to cirrhosis. And on the right side, during the splenic CTEP shows on the right and left hepatic lesions. So for CTEP, the lesions of the abnormality appears hypodensity, whether it is hypervascular or hypovascular. This is another case to demonstrate to you how useful the SMA CTEP. You see the pink one, the purple one is the abnormality one, the hypodense one. It could be with the portal thrombosis. And you can see the catheter is in SMA. So comparing the arterial portography and selective common hepatic ICTHA, you can correlate this hypodense into the tumor enhancement from non-selective to selective to super selective, avoiding this normal liver tissue to be injected with the chemo drugs or whether it is for Y90. So in summary, to compare the diagnostic CT arterial phase and venous phase, this is selective ICTHA, this is CTAP, the hypodense, and this is your nuclear medicine technetium 99M scanning, and this is your Y90. Now let me talk about the SIRT or selective internal radiation therapy. Here is where the angio-CT is very useful. There are two sessions for IR. The first one is the planning, wherein the technetium 99 is injected into the feeding artery of the tumor. There is a history of metastatic colon cancer with liver metastasis. Previously, Trium-97 on the right liver, but there is a segmentary lesion which is increasing in size. So for hepatic MAA, the vasculature, identifying the feeding artery, hemodynamic shunting, and try to be more selective injection of technetium 99M, the extent of the tumor, and determine if there's any extra hepatic enhancement subject for embolization. Once this patient was sent to nuclear medicine, the MAA particles are used to surrogate Y90 atmosphere, a stimulation of Y90 treatment, and they do all the calculations from lung shunting and TNR. So for this particular case, this is IVCT, and this is the celiac DSA. You have the left hepatic DSA, and when the catheter is in the left hepatic artery, IECT was performed. So you can see in comparing the IVCT on the left side, and on the right side you have the LSA ICTHA. So in this particular case, there is a gastric enhancement. So from the reference DSA, the injection of technetium 99, this is a nuclear medicine scan showing the tumor uptake in comparison to diagnostic CT, but at the same time there is a uptake also in the stomach. So during the Y90, it was decided to embolize the gastric artery before infusion of Y90. So this is the left gastric DSA, and this is the left gastric IACT. And if you notice, you can see the very selective enhancement of the gastric, and you don't even see the tumor. So this is a preamble for left gastric, and this is your post-embo for left hepatic artery post-embolization. So you don't see the enhancement of the left gastric. And for the CT, this is the left gastric ICT. You can see the enhancement of the gastric area. And for the post-embolization left hepatic ICT, so you don't see anymore the gastric enhancement. So in short, for Y90 infusion, it was injected into the left hepatic artery, and this is the uptake during the nuclear medicine scan. This is your MAA, and this is your Y90. Recommendations for CERT: always display the reference image with the vessel enhanced and bone landmarking as a reference. Intermittent fluoroscopy during technetium 99M and Y90 infusion. Of course, you need to support the catheter very tight, and radiographer need to focus during the entire procedure. So for the liver, this is the criteria for a successful ICTSA. You should be able to pacify the tumor for large tumor, for multiple lesion, and for single lesion, for you able to achieve the maximum enhancement of the tumor once you are able to demonstrate a hepatic vein. So in other words, the tumor will no longer enhance beyond that. So why hybrid angio-CT for this particular procedures? Studies have demonstrated that the use of HACT improves the accuracy and safety of the procedures, and leading to a better tumor response and increased overall survival rates for patients with liver cancer. Additionally, the real-time feedback provided with this advanced imaging technique allows for more immediate adjustments during the procedure, optimizing treatment delivery and minimizing potential complications. Allow me to share with you our very first complication, where the yttrium-90 was accidentally injected into the falciform artery. Patient developed of cellulitis on radiation dermatitis following the embolization for hepatocarcinoma. So a case of prophylactic embolization of patient with falciform artery. We conducted the study comparing the catheter-directed CTHA for yttrium-90, and the objective of this study is to determine the rate of prophylactic embolization of extrahepatic vessels in patients undergoing Y90 for hepatocellular carcinoma with the use of catheter. So based on the study, the use of catheter-directed CTHA in CERT of HCC was associated with a lower rate of embolization when compared to the other report that utilized in DSA alone. For difficult case like pseudoaneurysms, you can see the diagnostic CT. The pseudoaneurysm was embolized through percutaneous approach using CT-guided fluoroscopy. So once the needle is in the approximate area, DSD was done, and it shows that it is connected to a vessel. So on the right side, for post-embolization, you can see the glue injection. So are you able to identify whether you embolized the correct area? The IVCT was performed, and you can see on the left side a plane scan comparing from the diagnostic CT in axial and arterial, and also even the coronal plane. So another challenging here is the radiographers' skills for advanced workstation. This is just to share with you the utilizations of workstation using the diagnostic CT. This is your IBCT arterial. You're able to trace the feeding artery. It's a very not so clear vessel tracing, but somehow I can guide you where is the feeding artery. For some difficult cases, you're able to identify the feeding arteries, and are able to infuse the chemo drugs selectively. So having this system, it will avoid spray injection of chemo drugs into the liver. Is this beneficial? Of course, yes. And looking at the diagram, when using the EMBO plan or advanced workstation, if let's say you're using 5 to 10 minutes of manipulating the workstation in comparing to continuous fluoroscopy and injection of contrast, until such time you can identify the feeding artery. So you have to balance the benefits of using advanced workstation, although it's time consuming, but rather it is a beneficial on the part of the patient. Other applications for embolplan, this is a very difficult case, and from the reference they say you cannot identify easily, but you need some manipulations for you to trace the feeding artery. This is the 3D from common hepatic ICTSA, knowing the trajectory, and this is your DSA, and ICT selected was able to identify the correct feeding artery of this particular lesion. What about far advanced post-processing and image evaluation? Allow me to share with you, this is just a splenic embolization. So the objective of this post-processing is to identify in which particular splenic artery that can embolize only the 50% of the entire spleen. So this is the IBCT, and this is the volume calculations. And during the embolization, the ICT was performed and selectively identify in which vessel we can come up with the 50% of the total enhancement of the spleen. For this case with the previous lipidol, you can see the actual lesion from the MRI, and on the left side you can see the celiac arterial phase, and on the right side you can see the celiac arterial phase with iodine mapping lipidol. So from the plain CT, you can see some lipidol there, and comparing to the MRI. But for ICT, right hepatic ICT-HA, you can still identify the enhancement in comparing to the plain scan. But for using the iodine mapping from the subtraction data, you can easily identify these are all the actual enhancement, because the lipidol enhancement was already subtracted. For renal cryoablation, iodine mapping, I think I've shown this picture. This is to share with you. This is just an additional retrospective reconstruction to demonstrate well if your arterial phase is not so as good as the ideal enhancement, but at the same time you can use as a reference whether is there any unusual enhancement, like this particular case we thought this is a remnant tumor, but it was not. For prostate embolization, in between the right and left, sometimes when you are injecting so much contrast, when you do ICT, it's hard to identify which is the actual enhancement, but doing a plain scan before the ICT, you can easily identify this is the actual enhancement during the ICTA. It is also useful for post-processing of interarterial CT foot perfusion, and it helps us to analyze the arterial peak and soft tissue enhancement pre and post revascularization. Yeah, hybrid CT is very complex. There's a lot of challenges, and the workstations, injectors, advanced hardware and software, and you must understand you're buying a very expensive system, and sometimes it's very challenging as well how you're going to utilize it. Just like what I have shown you when I show you some iodine mapping and some dynamic scanning as well, if it's necessary. You have to find ways to justify that worth of buying this very expensive system would be helpful when it comes to interventional procedures. And the speed and efficiency from angio-CT imaging system or vice versa during procedures is very challenging for radiographer. From intravenous CT, from ICT, the mind setting, and the presence of mind, and the complexity, what imaging has to be utilized. This requires more focused attention when it comes to radiographers. So I have some tips here. Team effective workflow. Highly recommending a two radiographers during procedures. Of course, you have to understand the limitation of all the injectors. Collaborate. Always review imaging workflow. If there's a need for review or revision, take time, don't panic, and stick to your workflow. Always ask the IR the sequence of imaging plan. Technology advancement will never stop. Although the hybrid CT is a complex system, it is a very useful tool in radiological intervention, especially when complications occur intra and post procedures. Radiographer's role is to assist and help the IR during procedure, not only in technical aspect, but also in imaging analysis and assessment. It helps to improve patient safety and during procedures. Consistently maintaining the level of the acceptable standards in operation of the system during all the cases. Again, participate and support the IR to new treatment strategies and complications and applications. Well, just a take-home message, complex system but very challenging. Teamwork, and I think the planning of room layout for new installation for hybrid is even more challenging. Before I end my presentation, I would like to share with you, this is a Alphanex Body Club members launched in 2021 by Canon. Just a little bit throwback from 2010, my chance to meet our ISRRT president, Mr. Nepapong from Nepang. This was taken in 2010. In 2016, I had a chance to meet Donna Newman, our former ISRRT president, and Fosi Pierre. This was during the 19th ISRRT World Congress in Korea. And the most recent one is Professor Christopher Stillman. I think most of you are familiar with him, and I had a chance to meet him through a webinar session during the Theatre Society of Radiographers session. And recently also I had a chance to get invited in AVIR, wherein I had an opportunity to meet all those seniors and former presidents of AVIR in Arizona. So before I end my presentation, please allow me to share with you this saying: gaining knowledge is the first step to wisdom, but sharing it is the first step to humanity. These are all my references. And of course, I would like to acknowledge the SSR for giving me this opportunity, the IR radiographers team, IR doctors, and IR CPD team. Okay, thank you very much for listening and supporting my presentation. Good afternoon.
All right. Thank you, Mr. Padre, for the presentation. Please direct all your questions you have for Mr. Padre as well as the next speaker to the Q&A section of the Zoom meeting. Next up, we have Muhammad Fairuz. So Mr. Muhammad Fairuz holds a diploma in diagnostic radiography from Nanyang Polytechnic, a bachelor's degree in medical radiation science from Charles Sturt University, and a master's in health administration, as well as a master's in medical radiation science from Flinders University. He specializes in nuclear medicine. His past work includes experiences from CT imaging in NUH, National University Hospital, dental imaging from the National Dental Center, as well as working as a senior nuclear medicine technologist at the Singapore General Hospital. He works in the Department of Nuclear Medicine and is a clinical specialist for molecular imaging for Siemens Healthcare. Currently, he serves as a senior lecturer for the Diagnostic Radiography and Radiation Therapy program in the Singapore Institute of Technology. His presentation today delves into the crucial role of radiographers and how they are evolving nuclear medicine in healthcare. We explore the nuclear medicine roots, its transformation, especially with hybrid imaging and new radionuclide therapy. Radiographers have adapted to these environments, driving a paradigm shift in practices. They leverage their diagnostic imaging expertise and collaborations and have spurred innovation to enhance patient care. Join us in discovering the dynamic journey of radiographers in nuclear imaging.
Good afternoon, everyone. Thank you for joining this session. I would like to thank the SSR for giving this opportunity for me to share my experiences as a nuclear medicine radiographer. I'm Fairuz. I'm currently the lecturer for Health and Social Science in the Singapore Institute of Technology for Diagnostic Radiography and Radiation Therapy program. I am a radiographer by profession. I had experiences doing CT and general radiography with the National University Hospital before I moved on to Singapore General Hospital as a nuclear medicine radiographer for about 8 years, and then later joined with the Siemens Healthineers as the clinical product specialist for molecular imaging systems such as PET-CT and PET-CT. And today I'm going to share about the role of radiographer in the current nuclear medicine practice, and also there are extensions to this role. This is because the nuclear medicine practice has been evolving over the years. And I mentioned radiographers not to slight other profession, but most of the nuclear medicine radiographer, at least for Singapore and some parts of the ASEAN, most of them are actually diagnostic radiographer by profession. They graduated as a diagnostic radiographer, and some of them work within the radiology department, and their standard role is nuclear medicine. Some actually, after diagnostic radiographer, then they subspecialize into nuclear medicine. There are also a small handful of nuclear medicine technologists, not many. And we also have the medical technologists who do not have a diagnostic imaging background, but they're quite competent in this field. And also radiation therapies. This is even so in Singapore because the nuclear medicine department in Singapore actually branches off from the radionuclide therapy branch of the radiation therapy. So we have pioneers from radiation therapy joining the nuclear medicine, and they became nuclear medicine radiographers. So it is also prudent to know what is nuclear medicine. So to benefit those who do not have any idea of nuclear medicine, then we take a look a little bit on the clinical workflow, understand what is our daily routine clinical workflow, and then mention of a few evolving technology, especially hybrid imaging, the rise of theranostics. Theranostic has been a big buzzword in the nuclear medicine space, and understanding the role of radiography in NM and extension of the role of radiography because of the evolving change in the nuclear medicine practice, and we will conclude. So what is nuclear medicine imaging? Now you can see there are three modalities of imaging. We have the CT, MRI, and PET. So the CT and MRI offers greater structural imaging. So you can see very clearly that the structure and gross morphology. But when PET is concerned, it shows function. So this is clearly a brain that is dead. So you do not see any function or activity, even though the gross structurally looks very intact, doesn't show great abnormality in the structures, but when it comes to function, it is no longer function anymore. So this is where nuclear medicine plays a very important role. Largely functional imaging, physiological imaging. And in imaging, we divide imaging into transmission and emission. So transmission is basically there is a source that transmits to the patients. So whether it be X-ray, whether it be ultrasound, whether it be MRI, so it transmits into the patient, and then for X-ray, whatever remains will form the anatomical data. Whereas in functional, the source of the image is usually in the patient. So the source will be from the patient, and there will be energy emitted from the patient, and we will measure and detect this. And this is where emission imaging is practice principles in the functional imaging. So when we compare nuclear medicine with other modalities, like for example MRI, angio, and CT, mostly transmission and shows very good anatomical imaging. But nuclear medicine, largely functional, study of physiology, and the underlying principle be emission imaging. So for example, this is the coronal CTA, and you can see there's a little bit narrowing of the left anterior descending, but we're not quite sure how severe is this to the patient cardiac function. So what we do is we will stress the patient using either pharmaceutical or physical stress, and then we will see the perfusion of the cardiac. This is basically, this donut shape just correspond to the myocardium or the cardiac muscle seen as the short axis are slices of those. And we can see there's a reduced perfusion on stress. Then on rest, the myocardium becomes more viable. And this clearly shows signs of ischemia at the times of stress. And this stratify risk of patient having the next episode of angina, which offer clinician an idea whether the severity or the seriousness of whether to provide the immediate intervention or pharmaceutical regimen therapy. Then we have the glucose. So this is a PET CT FDG. So this is a head and neck patient has an oral cancer, was a huge part of the oral tumor was resected and replaced with a tissue flap. But on the oral contrast, you can see at first glance, there's no abnormality of tumor growing, or there's no gross lesion seen. But with functional imaging, you can see there is recurrence. Now, this changes the staging. This changes staging and also changes patient management. In fact, the patient might have to go for therapy, might have to go for systemic therapy like chemotherapy or radiation to ensure there is no possible recurrence. So this not only shows the size, if there is, but we get to understand the metabolic activity or metabolic changes of the tumor. And all this nuclear medicine imaging, we have to credit or pay homage to pioneers who had research and seminal work in the field of nuclear medicine. Shortly after Röntgen discovered X-ray, Becquerel also discovered this mysterious ray emitted from uranium salt, and later was studied by Marie Curie. So she studied the properties of this mysterious ray and coining radioactivity. By the way, Marie Curie has been the pioneer female Nobel Prize winner in the arena or the time where mostly Nobel Prize winners are actually dominated by men. Then we have George de Hevesy. He's a chemist, Hungarian chemist, who started the tracer principle, isotope tracer, and this is a very important principle in nuclear medicine. Then we have Ernest and Stanley, who invented the cyclotron. Until today, this design of cyclotron has provided the supply of radionuclides for PET CT scan. Then Emilio and Glenn discovered the workhorse of nuclear medicine imaging diagnostics, which is technetium-99m. And technetium-99m has been used for all diagnostic imaging in nuclear medicine. So Hertz is the first physician who started the radionuclide therapy with iodine for thyroid cancer. Until today, we do radioiodine therapy for thyroid cancer, for benign thyroid disease, and also management of that. And usually this thyroid, we use it for adjuvant therapy post resection of the thyroid cancer. Hal Anger invented the scintillation camera, whose design is still available in all our modern SPEC and SPEC gamma camera. And of course, in 1953, Edward and Michael is the first researcher who invented or initiated the design of PET for human imaging. So, and the typical clinical workflow. So, in a typical imaging clinical workflow falls under this three factor. One would be the biomarker production and distribution. So we have radioisotope that is produced in the cyclotron. This is how the cyclotron look like. So cyclotron can be available on site in the hospital, or the cyclotron can be available off site, meaning commercially available and then delivered to hospitals. And then we also have technetium generator. Technetium generator usually comes from a nuclear reactor available in overseas. So what we do is they would deliver this radionuclide in this generator, and then when it arrives in our labs, we will extract the technetium for purpose of labeling for whichever pharmaceutical agent that is used for the study. So this is the George Hevesy radio tracer principle, having the radioisotope produced, and then we label to the pharmaceutical agent that is designed to go to the area of interest, to go to the tissue of interest in a very cellular level, to go to the region of interest for imaging. And then we will look at the distribution in the body, and then by administering the dose into the patient and scan those area of distribution in the body. And then after that, followed by image diagnosis and image processing and diagnosis. Through radiopharmaceutical, this again, to mention, this is a tracer principle where the isotope is labeled with the tracer, and the tracer will go to the cell or tissue or organ of choice. So this is the example of a FDG PET. Now this is FDG PET using the fluorine-18 produced in the cyclotron, and we label with a simple glucose solution. So this is actually glucose solution. And this is an PET angiography from the whole body from head to thigh. And this can be another alternative. Researchers are looking for an alternative to CT contrast, because CT contrast, there are patients who have contraindication, particularly for poor renal failure, particularly for patients who are under dialysis or are allergic to contrast. So this can be another alternative of PET dynamic imaging. And as you can see, it was first the angiographic phase, and then you have the Bartow phase, and then the uptake phase. So these are the pharmacokinetics. And having PET imaging like this, you are able to understand the tracer of pharmaceutical of choice. Pharmaceuticals that are coming out post-research. Then you want to understand the tracer principle. You want to understand whether this pharmacological drug, the usefulness and efficacy of pharmacological drug. We will start able to study this under the PET scan. Now, the radioisotope must have this following the radioactive decay in order to produce the image that we need. So electron capture, positron and isomeric transition. Mostly it's positron emission and isomeric, positron emission and isomeric transition. So for positron emission, usually it's the fluorine-18 and other radionuclides, but majority is fluorine-18. So the fluorine-18, once we injected, it emits a positron. Now, a positron is an antimatter. It doesn't survive long outside. So once it meets an electron within proximity, it will annihilate, destroy itself, and it will produce two gamma photons that will go in opposing direction collinearly. And this will be detected on the opposing sides of the detector. And the isomeric transition usually for gamma Cameron spect, and this is basically the same is the same atomic number, nuclear number, but energy are different. So two energy state, so from unstable to a stable state, it releases a single photon every each decay event, and this is where the name single photon emission computed tomography comes about, or SPECT. So and you notice that a lot of our imaging we use gamma photon, so there must be a gamma photon emission in order to produce image of our gamma cameras or PET-CT. The beta emission is the therapeutic properties of the radionuclide. These are the ones that we use for treatment. These are the ones that we use for radionuclide therapy. And another one should be alpha. It's not here, it's alpha. Now, alpha is also another therapy. The decays can produce radiotherapeutic properties, and both alpha and beta doesn't go beyond skin. So it is selectively internal to the target cells or the target tumor, but the radiation in the surrounding or the adjacent organ, it's very minimal. So with the radio tracer and with the radioisotope of choice, you have many different images. So for example, you have this iodine 131. This is where Saul Hertz first founded radionuclide therapy. Usually we use iodine 131 for post-resection of thyroid cancer. So after we resect the thyroid cancer, the remnant thyroid is ablated. And because it also has gamma photon emission, and the gamma photon allows us to image areas that is possible metastasis of thyroid cancer. Gallium-67 is used for lymphoma imaging and inflammation, but nowadays this has been replaced with PET-CT. Then we have iodine 123 MIBG for neuroblastoma, for some pheochromocytoma. Then we have the bone scan, the popular and most often done. It can be MDP, HDP, or DPD bone scan. Then we have technetium 99M antibody. This is for bone marrow imaging. Technetium 99M maybe. In the past, we do use a whole body scan, but now we limit to more cardiac imaging and parathyroid imaging. Indium 1111 somatostatin is used for neuroendocrine tumor, and these two are for PET imaging. So FDG, F18, and sodium fluoride. This FDG is the main dose or main radiopharmaceutical that is often used in PET-CT. So all these tracers gives different imaging, and the choice of tracer is very important in understanding patient underlying pathology. So we need to see clinical indication and decide what are the radio tracer that is suitable for answering the referring clinical indication. Then we have the hot lab. So most of us have to work in a hot lab. Some of us involved in labeling that hot lab. We do quality control and also doing the measuring of those before we administer to the patient. And usually, most of the patient, the patient after injection have to stay for 1-2 hours so that we must ensure there is optimal uptake on that organ or region of interest before we can study them. Now, I keep mentioning SPECT and PET, right? So SPECT and PET are two different nuclear medicine systems. So single photon emission computed tomography, as explained before, are basically mostly isomeric transition that gives off single photon, and this will be detected by the two detectors usually available in the system. And positron is the emission of the positron when it meets an electron, then there will be annihilation, and there will be two gamma photon at opposite direction, and this detector will detect to measure exactly the exact position of the annihilation event, suggesting the location of the distribution uptake. And radiographers often we have to do QC on this post system. It's a daily QC to ensure that the system inherently have no problem, do not present any issue of quality control or image quality that may sometimes suggest differential diagnosis. So this is again example. Usually it's a dual head system. You can make it L-shaped for cardiac. So we normally make it this L-shaped collimator for cardiac imaging. Of course, it can be like one earlier where you can have two above and below so that you can do both imaging. And the gamma camera offers a lot of information on function. So for example, this is a cardiac imaging, and other than the perfusion information, you are able to understand the function of the left ventricle. And the information that usually the cardiologist would see in this stroke volume, would see the ejaculation fraction, and also able to predict ischemic dilatation or the possibility of having ischemia. Positron emission tomography, again, the workhorse of the PET-CT radiopharmaceuticals is usually FDG, and a lot of it has oncology application other than neurology. Neurology, normally we will look at degenerative clinical indication like Alzheimer and dementia. So PET and SPECT usually made up of more, or is widely available compared to PET. SPECT is about 57% because it's relatively cheaper than PET, and a lot of SPECT system is used clinical indication for bone imaging, whether it be infection, inflammation, or metastasis or fracture, thyroid for benign disease and also cancer. We have the lung, gastrointestinal and kidney function, neuroimaging like epilepsy or Parkinsonians, and therapy. Cardiac is very often available. Nowadays, we have dedicated cardiac SPECT system where we can do a lot of the stress and rest imaging to stratify the ischemia, to stratify disease of ischemia heart disease. And then we have also PET. PET, 90% of the imaging is oncology for staging, for diagnosis, and pre and post follow-up. And then we have cardiac imaging, also similar to the SPECT, but we use PET radio tracer. And neuro currently, there are a lot of tracers. They're able to detect early Alzheimer or early dementia. So this is early Alzheimer and dementia, and also we study many other oncological application of neuro, and also others include therapy, PET therapy imaging. And also to look at our small dot of ours in Singapore, we currently have 4 cyclotrons. So these 4 cyclotrons are the one that provide those PET-CT centers in Singapore. So 2 are commercially available. 1 is available in the US for research, and we have 1 in Singapore General Hospital. So in Singapore General Hospital is the only restructured or public hospital that has a cyclotron, and it also supplies many other clinics in hospital. SPECT system, we have about 9 SPECT system, and usually most of them are the cardiac dedicated system. And these are all the hybrid system that we have in Singapore. We have 13 SPECT CT, we have 17 PET CT. Out of the 17, 4 of them are in the restructured or public hospital, and then 2 PET MRI. 1 is in a private hospital, and the other 1 is for research. Now, since just the PET and SPECT only, technology has also advanced into SPECT CT and PET CT. We have now the addition of CT on top of SPECT. So sometimes we have the CT gantry, and then the anteriorly we have the 2 SPECT detector, which is used to detect lesion and to localize lesion, SPECT lesion. Same thing for PET. We also have the CT, and we also have the PET gantry. Now, these 2 are hybrid system. Even though they are hybrid system, the acquisition takes place in 2 parts. So you have the CT, which usually takes less than a minute, and then you have a PET acquisition. Depending on the radio tracer and the study, it may take up to 15 to 20 minutes. So that's why it is imperative that the radiographer explain to the patient and ensure that patient doesn't move between these 2 acquisitions, because if the patient move at any time, then there will be what we call hardware misregistration, meaning one part of the scan patient and it does the image, we are not able to register 2 images together. And what do I mean by registration? Now, the CT has an advantage. The CT if you look on our just general nuclear medicine images, you see things like this. Unusual distribution accumulation of uptake, but we can't say for sure exactly where it is at which part of the body. And for the referring clinician also, they cannot make up an understanding what does this correlate to. But having the CT anatomy, it provides structural landmark to give a better understanding where does this abnormality correspond to. And for surgeons, you can also have landmarks so that they are able to minimally remove the affected organ or doing biopsy more accurately or with greater precision for histological evaluation. And also it increases specificity of the scan. For example, in the bone scan, we sometimes have this a lot of abnormal uptake. Most cases they are quite abnormal, but in patients, for example, elderly who also have degenerative physiological degenerative, some of this uptake may correspond to those. So it's sensitive enough, but it doesn't pick up exactly whether this is degenerative pathology. So having the CT, we are able to have structural information of those areas of metabolic changes or those areas of uptake or abnormal uptake, and the fusion of both increases the specificity of the scan and giving referring clinician a better understanding so that they can prescribe appropriate treatment and improve patient outcome. Then another reason is also attenuation correction. Attenuation correction is just simply when there is uptake in the body here. As you can see, this shows very unclear. At the first glance, you will see that the patient is pretty stable, doesn't have metastasis. Reason being is because the gamma photon from this lesion has to traverse considerable amount of tissue, and most of the energy gets lost. So as it traverses through, and when it gets detected, then the detector form an image that suggests that this is the activity or this is the distribution, when really it is supposed to be like this. So what we do is we take the CT, we do the CT to do an attenuation correction, and the CT will provide the linear attenuation coefficient of all the tissues, and we will map it to this radiopharmaceutical energy, and then it will be attenuated, corrected. These two have a different implication. This have a different staging and this has a different staging. So it is very important that all our SPECT images are attenuated, corrected, so that we are able to see the true disease progression. And yes, I have a lot of colleagues in nuclear medicine keep saying that nuclear medicine is unclear medicine for the longest time, because we see blobs, we see cluster, but not actually sure what does that all actually means. So by doing this, by having CT, we improve the resolution of SPECT, making it clear medicine. Theranostics recently in nuclear medicine has been a big hype. So there has been great interest in investing in theranostics because it's promising and is one of the primer of personalized and precision medicine. Traditional nuclear medicine, particularly in disease medicine, disease management, we always involved in doing screening of diseases, early diagnosis of diseases, and staging and providing an accurate prognosis. But beyond that, we also theranostics is able to have an appropriate selection of therapy for patient, and then we will measure the efficacy to see the therapy response and follow up, and personalized medicine. Now, theranostics is able to look at the patient trait, not looking patient as just a number, but just a patient trait, unique features of that patient, the tumor biology, clinical history into therapy. And other than lesion detectant for purposes of anatomy versus function, we also improve precision medicine, directing the therapy and to the tumor biology and sparing the adjacent or surrounding tissue. with minimal side effect. And the theranostic principle usually comes with a pair. Now, this is the same thing as the George Hevesey's tracer principle. It's like a lock and key. So we have the lock and key. The lock is the cancer cell, which, and with the correct key, you open the door, right? So in this case, the key, we link it with a radioactive compound. Now, this radioactive compound can be for diagnostic purpose. That means it emits gamma photon, so that it provides a roadmap for exactly where the tumors are, and we can also calculate dose whether the tumor received the maximum dose while sparing the surrounding tissue. Then on the next cycle, on the first cycle of treatment, we replace this diagnostic the radioisotope with a therapeutic isotope like Y90 and lutetium-177. They are beta emitters. And the advantage also using this tool, they also have gamma emission. So we are, other than actively transmitting radiation to the tumor cells, we are also able to see exactly where this therapeutic radioisotope goes distribution in the body. So we have the diagnostics and the therapy. So the word therapeutics and diagnostics link together to form theranostics. So this is an example now for metastatic castration-resistant prostate cancer. What we do is we will do a pre-therapy imaging of PET scan, a gallium-68 PSMA PET scan. So we do an initial imaging to see where are the primary tumors and where is the metastasis. Then we replace that with targeted therapeutic radionuclide, and this is delivered, administered and delivered. And we also can image them, the distribution. Then we do another post scan to see the treatment response, and then we keep repeating this many cycles until there's therapy response and negative follow-up. So an example, we have this gallium PSMA. Now these are physiological, which means normal uptake of salivary glands, the liver, the spleen, the kidney, and the intestine. But there's also widespread metastasis, right? So this already provides us the roadmap exactly where we are going to target. Then we have to do dosimetry to calculate dose, how much that is going to deliver to this, and how much organ and kidney will receive. So as long as it doesn't go beyond a threshold, then we would prescribe the treatment. The nuclear medicine physician will prescribe the treatment, administer lutetium-177, and then first cycle, second cycle, and third cycle. And then after that we repeat the PET scan again to see the therapy response. And usually these patients, when we do lutetium-177, patients are usually discharged on the first day. This we can do as a daily do as an outpatient, so the patient do not need to be admitted in hospital. This once administration, the patient can go back, because the radiation risk to the public is really very low. Some of our theranostic pair, we have MDP for bone scan. This will provide the roadmap for bone metastasis. Then we use Sophigo or radium-223 for pain management. Radium-223 is actually alpha emitter. So this is usually for palliative treatment for bone mets. This does not offer any imaging. So usually we do a bone scan, then we treat, and then we do again the bone scan to see whether the tumor response. Technetium MAA and TheraSpheres, the one explained by Cornelio. So technetium MAA provides the arterial supply of the tumors in the liver. So it treatment, then we will do the dosimetry and calculate the dose, provided there is no liver to lung shunt. Then once it is safe to prescribe, the radio isotope of choice that we use will be Y90 TheraSphere, and this will selectively goes to the arterial supply of the tumor. As we know, liver is mostly supplied by portal vein, but the arterial supply is selectively only to the cancer that we block and ablate. Then We have thyroid, iodine 123 for diagnostic, and iodine 131 for ablation. This is usually adjuvant therapy to surgery. For thyroid cancer, MIBG 123 for diagnostic, and 131 is neuroblastoma pheochromocytoma. In Singapore, we don't use iodine 123 for thyroid cancer. We use iodine 133. We use technetium actually, free technetium for thyroid imaging, and then we will use iodine 131 for ablation. We use MIBG for diagnostic and for therapy for neuroblastoma and pheochromocytoma. Indium 111 ultratype for SPECT, imaging of neuroendocrine tumor, or gallium-68 dotardate for neuroendocrine tumor imaging. And then we use Y90 and lutetium-177 for treatment. Gallium-68 PSMA and lutetium-177 PSMA for prostate therapy. So the role of radiographer. Radiographer has been very important in the continuum of care. We are dependent on technology. Technology really changed rapidly, but we are always involved, and we form a very important link between patient care and technology. So with investigation, in the diagnosis, in the image-guided treatment, and the follow-up. Similarly to nuclear medicine, we also involve in the whole spectrum of care within inpatient, but we don't do it alone. We work with a multidisciplinary team, like for example, the nurses that we work with, also radiation protection trained, so they are trained to deal with radioisotopes, and normally they are in charge of taking care of the patient post-therapy or post-imaging, advising the patient. Then we have nuclear medicine physician. Nuclear medicine physician is actually a physician. They prescribe treatment. They see patients, for especially those patients who goes through theranostics. They read images, PET and SPECT CT images, and sometimes they vet protocols. So sometimes you watch and you vet protocols for a certain clinical indication. Then we have physicists. We always work with physicists because QA, QC for all our SPECT system and calibration of radiopharmaceutical is very important. We do it on a daily basis and documented to see any to study any trend of issues and problem, or technical issues or problem. But radiographer, other than we have to do KOA QC daily, weekly, monthly, we also prepare radiopharmaceutical. We are involved in the patient care to ensure that patient is properly taken care of and optimally during the scan. Administer radiopharmaceutical, PET imaging, and SPECT imaging, processing and quality control and reconstruction of images. But recently, we also are involved doing CT imaging and dosimetry. This is because the evolving technology and the rise of theranostic have made radiographers do extended role. Now, for CT imaging, most of the hybrid imaging can be also a standalone CT because it's a diagnostic CT, the same capability you'll find in the radiology department. In fact, there are a lot of other departments where I did training use the CT for to clear backlogs of in the radiology department, doing emergency CT. And also, I also see some use the CT for radiation CT simulation. And the same capability is required in training of doing CT. That means you are able to use contrast, you are able to do multiphasic CT, and you are able to do different acquisition of CT. And also the gatekeeper of dose, because other than the tracer, they already inherently have the dose, but we also need to be careful on the CT parameters. That's why the training is very, very important in doing CT in order to provide radiation dose safe for patient. But in the past, we used to have radiographers only doing operating the CT and nuclear med operating the nuclear part, which is not a very productive use of workforce. And I remember this many years ago in Australia. My colleagues told me before, my friends who would work in Australia. But now things have changed. The capability it's required that all nuclear medicine technologists or radiographers be competent in CT, and not only the low dose CT, but also the entire spectrum of the CT imaging. This so that to ensure this continual care within the nuclear medicine, rather than sending patient back to CT doing the CT scan, the patient can do everything in the nuclear medicine. Then dosimetry, because the rise of theranostics, there is a need to do dosimetry. Now, radiographers actually championed in doing segmentation. I know for a fact that in the past, dosimetry was done by physicists, but physicists are not quite good in reading sectional anatomy images. So as you can see, this dosimetry, we need to do quality calibration. This orange is the physicist and blue is the radiographer. And these are all done by radiographer. And then we do the void segmentation. I know for a fact that when I was in nuclear medicine, I did dosimetry for Y90. So when the technetium MAA was injected, I did the therapy. I did the dosimetry for MAA, and then suggested the treatment to the doctor or nuclear medicine physician before nuclear medicine physician prescribed, and then understand an idea from radiographers in terms of imaging protocols and also segmentation of the organ. And I also have colleagues who did it for lutetium-177 as well, nuclear medicine radiographer. So this segmentation is already an extended role on the existing nuclear medicine role. So, conclusion: nuclear medicine has been evolved since the early days of of imaging because it helped to understand the disease mechanism, and it helped to pave way for more precise and personalized medicine, which for individual patient, unique understanding their unique trait. Nuclear medicine offers many possibilities of diagnostic and therapeutic, but these require extension of the existing roles of radiography in nuclear medicine. But that being said, the role of radiography in nuclear medicine in the face of advancement of technology serves a very crucial human link to quality patient care. Thank you.
All right, thank you, Mr. Fairuz, for the presentation on nuclear medicine. We will start with the Q&A for both presentations. So first off, I would like to offer this platform to the panelists. If any of the panelists have any questions they would like to raise to two of the speakers here, Mr. Fairuz and Mr. Padre.
I have a question for Cornelio, Mr. Cornelio.
Yeah, please go ahead.
You hear me?
Yes, I can hear you.
Yes. I saw you show in hybrid system room you need to radiographer. How you can share the workflow for two radiographer in hybrid system room. The first question. The second question, you recommend for one. I feel if radiographer work in hybrid system room, like very busy. I feel very busy, and like a cook. I like a cooker in kitchen, and you can recommend for one young radiographer and technologist how they learn something if they want to become the line specialist in like you. For example, they must they must understand CT hybrid and angio hybrid and ESA and US. You can share your experience for for young radiographer? Okay, 2 questions.
Okay, that was a very good question, and this is a complex system, and now you're giving me a very complex question also. Anyway, so in practice, as I mentioned in my slides, different hospitals have different practice. Who is supposed to operate the C-arm of the table? I'll give you an example. In Japan, the radiographer is just sitting outside. They don't control the C-arm of the table. I'm not so sure whether it's still in practice. So the reason why I'm proposing 2 radiographers, since we are the one controlling the table and the C-arm, one radiographer is inside manipulating the C-arm of the table and the radiographer outside. So again, for the major components that you are operating during procedure, especially for vascular cases specifically, there is a intraarterial CT and DSA imaging involved. At some point, let's say, for example, for the hepatic case, and you have done like a roadmap or proper hepatic ICT, wherein you can opacify well the hepatic arteries, and you need to identify the particular artery that supplies the lesion. The radiographer from the control room can help to do the embo planning or identify the feeding artery while the procedure is going on. Unlike if you are alone, just manipulating the C-arm on the table, you have no chance to operate the advanced workstation. You must understand, based on my slides, so it has to be well balanced, the benefits of advanced workstation. Otherwise, you are giving contrast and exposing radiology and the patient and the team itself for unnecessary radiation. However, if you are able, if one radiographer can identify the feeding artery with the correct trajectory, you are helping the radiologist. Bear in mind, in intervention, it is not a one-man show. It's a team. The radiologists, radiographers, and in our practice, the radiologist also depends on you. So you're not only manipulating the C-arm, the table, but you're giving them information. What did you find? It's the focus. The focus is very critical. From non-vascular to vascular cases, it's not easy for radiographers. So in my experience, sometimes I can only identify these very tiny vessels when I am working in the workstation, but I am not manipulating the C-arm on the table. And that's the reason why I am highly recommending 2 radiographers in our setup. Talking about the under GA cases, if you notice, they're very crowded. The preparation itself is very important. It could be the pre-preparation, the middle, and the post procedures. Okay, talking about the your second question, if I understand correctly, just allow me to share with you in our practice. It's also related with the other questions, like which is beneficial, whether it's a CT experience or angio experience. In our practice, let me share with you how we train radiographers. We started a training for basic single modality or an angio CT system. There is where the foundation starts from the training in IR. So in this first base of training, you'll be exposed to vascularity, and it's also an introduction to cone beam CT. So I understand in some places the angio CT is not so popular yet because of some it's very expensive, and in some cases they are using the cone beam CT for embo-get embo-plan. However, you must understand also, this is also related to the questions, the cone beam CT and angio CT comparison has already ended. It's because you must understand the limitations of cone beam CT. I've given a very good example. For cone beam CT, you are limited into FOB, scan coverage, and in some cases, like for liver, the respiration is very critical. So you must understand you're dealing patient with is a sick patient. Unlike in diagnostic, most of the patient, it could be ambulatory, it could be sick, but in intervention, definitely your patients might not be able to follow some basic instruction. And in addition to that, even the soft tissue reconstruction. So it's very difficult to compare now when it comes to image information that you gain from cone beam CT and angio CT. So going back to the training, so in SGH, before you be trained in angio CT, you must have a very good foundation in single modality, vascularity, workflow, anatomy, and hemodynamics, so that when you come to angio CT system, we're only focusing more on the CT part because you're already expert in angiofluoroscopy or cone beam CT. But again, as I mentioned earlier in my slides, the CT in intervention is entirely different. I have shown the sample why the diagnostic CT protocol, sometimes it doesn't work in interventional. There is a lot of flexibilities. You're not always doing in arms up position for CT body, it's always arms down. And you have to consider those contributory that will cause image quality not as good as a diagnostic CT. The intraarterial CT, as I mentioned earlier, is a very challenging because we don't have a proper protocol. Unlike for CT liver, as long as I know in some places, it is a patient's weight basis. Your patient's 50 kg, you can get 3 minutes per second. But in ICT, it's different. We always based on the reference DSA. I'm not going into detail, but those are the flexibilities. Yes, there's an advantage for CT radiography because you're familiar with anatomy and everything. That will be very helpful. We cannot leave it as not as a disadvantage. But as I said, this is how we start the training. Otherwise, if you send a radiographer directly into very complex system, it might be traumatized the radiographer because it's entirely different. There is no straightforward imaging when you need a CT or ultrasound for fluoroscopy. Of course, in ultrasound, we are not sonographer. However, as I have shown in RFA liver, the preparation is also part of the job of radiographer, like loading CT data and MRI data for fusion imaging. Although most of the radiologists, they know how to do it, but still, as a radiographer, it's still part of your responsibility. You must be aware. So in that aspect, we also identified in our team, we cannot be expert in everything. So we have to identify your radiographer, potential radiographer, who can be expert in ultrasound, who can be expert in angio CT, who can be expert in neurointervention. So if you notice, I didn't even share any neuro case because angio CT is not ideal for neurointervention. I think I don't want to spend most of the time. I think I answered all your questions, including the angio CT and cone beam CT comparison.
Thank you, Mr. Padre. Do we have anyone else in the panel list that has any questions from either speakers? Okay.
Yeah, I saw one question for a Q&A box. If have a free time, I have a question for Mohammed. You in Q&A box, I have one question from Mohammed first.
For Mr. Fairuz. So perhaps you can go towards the Q&A box for Mr. Fairuz. How do you see the future of MR and MR PET? Also asking your opinion on, from your experience, how do different hospitals train their radiographers to be competent in both MR and nuclear medicine?
For MR PET, it's not really a game changer. That one I have to put it first to begin with. In Singapore, we have two MR PET. One is in a private hospital and the other one is for research. But most of the bulk of the case is actually MR than the MR PET. The reason, and most of the radiographers are actually MR trained to do MR PET. So when I was in Siemens, when I did the MR PET, when I do go down, I just do the PET parameters. The MR is a little bit complex. So usually it would be an extended role from the MR radiographers to do PET. When I went to research centers in US, both radiographers, they have a mix. They have a PET radiographer and the MR. So, and the PET is a very small component, but the large component is usually MR. So usually the training should have, you have a MR trained radiographer come, and then with that predisposed training or prerequisite training will offer you a better standing to understand the not too easy but yet complex nuclear medicine. And MR PET has been always for children hospital for research, largely research. I know Hong Kong, Thailand, they do MR PET, but in this region, I notice a lot of it is research purposes and also, yes, for clinical purposes like brain and also for prostate. And as usual, mostly are MR radiographers, an extension role to nuclear medicine.
All right, thank you so much for your answer. Would like to ask the floor, anyone else has any other questions for the two speakers? Perhaps you can type it in the Q&A box. And if we miss any of the questions, we will try and get the answer disseminated to everybody.
Very. I saw you saw in your workflow in have a nurse, physicist, and radiographer in nuclear medicine. You can tell us how become one radiographer nuclear medicine in Singapore. Very important. Yes.
Okay, so we have a standard provision that comes out by the Ministry of Health. And the main ruling is that, firstly, you have to be diagnostic radiographer trained, or you are nuclear medicine trained, or you have experience in a nuclear medicine environment that you have been OJT, because there are I've known a lot of very expert nuclear medicine in the field who are medtechs, and these are those who have many years of experience doing pharmaceutical and doing clinical imaging. So we have that directive for the ministry to say that, okay, as long you fulfill this whether by qualification or by experience, and again you will be supervised, then you can be nuclear medicine radiographers. The nurses are general nurses, but they are of course under the supervision of radiographers and nuclear medicine physician. And the physicist is a subspecialized. However, in Singapore, we do not have a subspecialized physicist. They are general physicists. Unlike other countries, they have a nuclear medicine physicist and radiology physicist. Singapore, we don't. So most of the specialization come from the on-the-job training. I hope that answers your question.
Yes, thank you. Yes, I saw the nuclear radiographer nuclear medicine in your workflow very important and understand. Okay, thank you so much. Thank you.
All right, thank you so much for the answer and the questions from everybody. If there are no other questions coming from the panelists or the attendees, we would like to have Ms. Pichi Luna to do the closing address for this 30th CPD Asia.
Yes, sure. Thank you, moderator Tan Han Min. And again, thank you very much to SSR President and to our panelists. We have the SSR that has provided us with two great speakers. Thank you, speakers, Mr. Cornelio Gutierrez Padre and Mr. Mohammed Pyrus. We have learned so much from your very interesting discussions. And so now I know everybody's excited to know about the next exciting online CPD Asia schedule. So without further ado, please welcome Mr. Yusuke Akita, the Academic and International Director of the JSMIM, the Japan Society of Medical Image Management, to give an invitation for the next Asia CPD.
Hey, hello everyone. Good evening or good afternoon. So, Japan will host the next seminar. This is the first time. Thank you for letting us participate in CPD. So, okay, may I share my presentation? Just wait. これかな? Can you see that?
Yes.
Okay. Okay, so the next seminar is on November 11 GST time from 5:30 p.m. This is GMT +9. This means if you are in Macau or Philippines, for example, you are from 4:30 p.m., right? And the theme is medical image management. We'll introduce Japanese rules and cases. And let's discuss how it is different or what the same with your country. So today I have something I want to try. I will share the next presentation. Can you see this? Okay. So if you can see this, right, so please read the QR code below left by your smartphone. And please answer the question. Oh, thank you. Yeah, the question is, do you enjoy CPD as your seminar? So your question is yeah, or of course, awesome, or thank you, everyone. So it's good, thank you. So we'll use this tool to discuss with you in the real time next. Oh, thank you, everyone. Magnificent. So thank you all. Thank you, Singapore Society, and see you again on November 11. Thank you, PT. Back to you. Salamat po.
Yes, salamat po. Thank you, Mr. Yusuke Akita. As you know, Japan Association of Radiological Technologists is one new society member of the CPD Asia, and we are very much excited to have you next month as you host your first CPD online program. So in closing, we would like to give thanks to the support of our many sponsors and the VT Healthcare Vietnam. Also, we are very much grateful to our two great speakers, to the host society, Singapore Society of Radiographers, from the President Denise Chu, to our moderator, Tan Han Min, to all the SSR organizing committee, and also to the support of all the member societies, presidents, to our very hardworking CPD Asia team, and to all the registered participants from Singapore and from all parts of the world. We will see you next time, again next month, November 11/11/23. Again, I'm Peachy Luna, and I say thank you, everyone, and have a great day.
Thank you.
Thank you,
Thank
everyone.
you. Bye-bye. See you next time. Thank you.
Bye-bye, everyone.
Bye-bye.
Happy birthday, President Fernando Koch.
Happy birthday.
Thank you.
Thank
See
you.
everyone in November.
Thanks, everyone.